Welcome to the third annual Clinical Pearls from JCEM Case Reports. I'm Bill Young. I serve as the editor-in-chief of the journal. Co-chairing the session with me is Dr. Adina Turku to my right, who's the deputy editor at JCEM Case Reports. We have 3 presenters and 3 content experts today. The presenters have 7 minutes to present their case or cases, and then we'll have about 2 minutes Q&A with the audience after that, and then we'll introduce our content expert, who will have 5 minutes to share some clinical pearls with you. Like all sessions at Endo, the session's being recorded. In addition, we're going to feature a verbatim transcript as a special article in JCEM Case Reports, which we hope to have come out in probably September issue. Well, with that introduction, we're going to start. Our first speaker is Dr. Angelica Theodoro, a research fellow at Memorial Sloan Kettering Cancer Center. She's going to be discussing successful management of Cushing's disease with metirapone throughout pregnancy, a report of 2 cases. Angelica?
Good morning, and thank you for the opportunity to present. Today, I'll go through 2 cases of Cushing disease in pregnancy, successfully managed with metirapone from preconception to delivery. Let's start with a brief introduction. Cushing syndrome in pregnancy is extremely rare. Unlike the non-pregnant population where Cushing disease dominates, pregnancy-associated cases are usually adrenal adenomas. Only about 40 women have received any pharmacologic treatment, and until now, continuous metirapone from preconception to delivery has not been reported. Current guidelines advise bilateral adrenalectomy before conception for women who are already on medical therapy. When Cushing is diagnosed after conception, transsphenoidal surgery for a pituitary source or adrenalectomy for an adrenal source is recommended, ideally in the 2nd trimester, yet many patients are not candidates for surgery, so medical management is an option. We should note here that no drug is FDA approved for Cushing in pregnancy. Our first patient is a 31-year-old woman diagnosed with Cushing disease in 2011. 5 years after transsphenoidal surgery, she developed recurrence without a visible tumor on MRI. Ketoconazole was tried first, but due to severe hepatotoxicity, it was discontinued, and metirapone was initiated. Several months later, she expressed her desire to conceive, but declined adrenalectomy. After discussions regarding the lack of FDA-approved drugs for pregnancy, the patient proceeded with IVF while on metirapone, and following a miscarriage, she conceived twins. Throughout pregnancy, we monitored her urinary and late-night salivary cortisol values every 3 to 4 weeks. The graph shows the urinary cortisol in blue and serum cortisol in red line. The upper limit of normal for urinary cortisol is shown with the blue dashed line. We can see that her urinary cortisol stayed within the upper limit except for a modest rise at 16 weeks. Having in mind that normal pregnancy itself raises cortisol, we tapered the dose to 250 milligrams 3 times daily by 23 weeks. At 37 weeks, she delivered 2 healthy infants. The patient continued metirapone peripartum, and stress-dose glucocorticoids were given for 24 hours perioperatively. Postpartum, she developed hypertension, requiring only a brief course of nifedipine, and she was normotensive within weeks. 3 years later, she remains biochemically controlled on metirapone, and her twins are doing well. The second case is a 29-year-old woman with recurrent Cushing disease since the age of 12. She had undergone 2 transsphenoidal surgeries, followed by gamma-knife radiosurgery and a course of ketoconazole. In 2016, recurrence was confirmed. She was reinitiated on ketoconazole and expressed her desire to conceive. However, she declined adrenalectomy, and given the potential teratogenic effects of ketoconazole, she was switched to metyrapone and conceived naturally. The graph again shows the urine cortisol in blue and serum cortisol in red line. Unlike case 1, her urinary cortisol remained 2 to 4 times the upper limit of normal throughout pregnancy. Yet, she was clinically well and the fetus grew appropriately, so it kept the dose unchanged. The patient went into labor at 39 weeks. She stopped metyrapone 36 hours before delivery and did not receive stress-dose glucocorticoids. She delivered a healthy baby girl who was monitored in the NICU for a day. Metyrapone was resumed 4 days postpartum. 1 week later, however, she was admitted for a day with preeclampsia, which was successfully managed with labetalol and a magnesium drip. Metyrapone was then increased to 5 times daily, and the patient was able to discontinue labetalol 3 weeks later. Although she experienced labile blood pressure for a year, this subsequently resolved. 5 months postpartum, her urinary cortisol was well controlled. The patient has been doing well, and her 6-year-old child shows normal development. So, why are these cases difficult? As we can see in the figure, during normal pregnancy, the placenta produces CRH, which stimulates the hypothalamic pituitary adrenal axis. Cortisol-binding globulin also rises, and serum and urinary cortisol physiologically increase 2 to 3-fold. Dexamethasone suppression is also blunted, so our familiar cutoffs do not apply. For women on adrenal serotogenesis inhibitors, guidelines suggest a urinary cortisol about 1.5 the upper limit of normal. Late-night salivary cortisol could be superior, as circadian rhythm is thought to be preserved in pregnancy. Nevertheless, optimal target ranges still remain inconclusive, and it's unclear if biochemical values correlate directly with clinical outcomes. And our cases demonstrate exactly this point, as case 1 had favorable outcomes even though we lowered her dose and kept urinary cortisol within the upper limit, and case 2 also did well despite urinary cortisol values well above the upper limit. As for metyrapone, it blocks 11-beta-hydroxylase, allowing upstream mineralocorticoids to accumulate, potentially raising blood pressure and in theory increasing the risk of preeclampsia. Both our patients were normotensive during pregnancy but developed hypertension shortly after delivery. The same block can shunt precursors into the androgen pathway. In the fetus, that raises concerns for female virilization, but to date, no documented cases have confirmed this, even ours. An important thing to keep in mind is that recent advances in Cushing therapy may improve fertility, and this really emphasizes the need for both contraceptive counseling and pregnancy planning while being on long-term medication. Even though not FDA approved, metyrapone should be considered in women with Cushing when surgery is not an option, but we definitely need further data on the optimal biochemical values that should be targeted in each trimester. I would like to thank my mentor, Dr. Eliza Gear, for these cases, and thank you for your attention.
Angelica, thank you very much for that presentation. 2 really challenging cases. If you have any questions for Angelica, please come to the microphone. It's in this aisle here. Just introduce yourself and where you're from. So I had a question for you, Angelica. You went with metyrapone. Was there a discussion at the beginning of alternate agents?
Thank you for this question. Yes, there was a discussion, and given the available case reports at the time, we concluded that metyrapone was the safest option since ketoconazole is considered teratogenic. Cabergoline has been used in several prolactinomas, but it's not so efficient in Cushing disease. So at the time, metyrapone was the best option for the patients.
And Angelique, was was from 2016. Was this before osilodrostat was available? Both of the cases?
Yes, both cases, and also didn't have any data on osilodrostat on pregnancy at the time.
Any questions from the audience? Okay, I'm going to invite Dr. Beverly Biller up. Angelica, thank you very much. So Dr. Beverly Biller is a professor of medicine at Mass General in Boston, and she's going to share some insights on management of Cushing syndrome in the setting of pregnancy. Beverly?
Thanks so much. Well, thank you for a truly outstanding presentation. And I was so happy when Bill picked your article for this session because I think that pregnancy during Cushing's, or in your case, it was known to be planned before the pregnancy. I mean, it was known that she wanted to get pregnant. A pregnant Cushing's patient is one of the single most difficult things we do. It's extremely stressful because there's very little data, because the patients can get really sick. And as you highlighted in your article, although I know you didn't have time to go through, the morbidity is very high, both for the mother and for the fetus. And so think about the fact that she presented 2 cases, but there were actually 5 patients being treated because there was a twin pregnancy and a singleton pregnancy and the 2 mothers. So if you think about taking care of 5 patients when you're really just treating 2 mothers, it's a lot of responsibility. So I think your paper and also some of the points you just made bring up 4 important things about treating a patient with meteropone during pregnancy. And I actually agree that that is the best choice, not because there's any approved drug, but because we just have the most safety data from case reports. And so the first thing that you did that I think is so key is to be mindful of the fact that the target isn't normal cortisol. It's normal pregnant cortisol, which, as you pointed out, is higher than normal. It's interesting to speculate whether that normal level should be even higher in a twin pregnancy, and data are actually conflicting. There's a paper that says yes and a paper that says no. So I think you did the right thing. The second thing that is really critical during treatment of pregnancy with meteropone is being mindful, as you were, of the buildup of potential precursors proximal to the 11-beta hydroxylase blockade. 11-deoxycortisol can cause hypertension and hypokalemia, and I know you monitored for those. When we have pregnant patients on meteropone, we send them once a week to their OBGYN for blood pressure and potassium monitoring because of that risk. And fortunately, the androgens weren't a problem, as you highlighted. The other thing you mentioned is the use of perioperative steroids if needed, and that's key because if you're blocking the cortisol at the time the woman goes into labor, she can't do the physiologic massive increase that normally occurs in the peripartum. It was interesting to me that one of your patients chose to stop the meteropone and then not have to take steroids. And the last point that you did so well, and that came across, I think, a bit more in the paper, is monitoring the newborns, because meteropone does cross the placenta, so there's a risk that the babies could have adrenal insufficiency. Unfortunately, I understand they didn't, so that's great. I think your cases also bring up 4 important points that are true for any patient with Cushing's, not just those who are pregnant. And the first is considering a second transphenoidal surgery for Cushing's disease at the time of pregnancy. All of the guidelines, including the European Society guidelines published in EJE in 2021, do say that a second trimester transphenoidal is fine. I know one of your patients had already had 2 operations, so that would be less likely to consider. But the possibility of remission from a second transphenoidal is lower than the first, but it's still around 50 to 65%. The second thing one of your patients highlights is that Cushing's disease recurs at a much higher rate than we used to recognize. And so all patients, pregnant or not, who are in remission from Cushing's need to be monitored for recurrence. The third thing is that recurrences after radiation are even less well recognized. And it was interesting to me that the patient had a 14-year period of remission from radiation and then recurred. We have almost no data about that, but we are starting to see it as well. So I think that's something else we need to be mindful of. The last point, which you didn't dwell on too much here, but which was in your article, is that I noticed that currently, or at postpartum, the patients are being treated with a higher evening dose. And that's something that we're hearing a lot about, even here at this meeting yesterday. Isadori and Ferrari have published about this and presented the concept of blocking cortisol more at night to reproduce the natural diurnal variation. So well done, and lots to learn.
Great. Thank you very much, Beverly.
With this, we'll move to our next case. It's a case of metastatic choriocarcinoma-related perineoplastic thyroid storm. Will be presented by Dr. Nidhi Garg, who's a second-year internal medicine resident at Baylor, Texas.
Good morning. We present a 38-year-old female who presented at 6 weeks of gestation with vaginal bleeding, lower abdominal pain, fatigue, muscle cramps, nausea, and vomiting. Her HCG levels were more than 600,000, and a transvaginal ultrasound confirmed intrauterine molar pregnancy. She underwent dilatation and curettage, and histopathology confirmed choriocarcinoma. She was discharged, and she lost to follow-up, and after 4 weeks, she came to the ED with chest pain, palpitations, malaise, nausea, vomiting, and shortness of breath. Her examination was unremarkable except for heart rate of more than 150 beats per minute. Her labs shows increased AST, ALT, TSH was suppressed, free T4 and free T3 were elevated, and the beta HCG was more than 900,000. The Buch-Bertowski score was 45, which was highly suggestive of thyroid storm. She was managed in the ICU. IV fluids were initiated, started on IV steroids, hydrocortisone, 100 milligrams 12th hourly, followed by 50 milligrams 12th hourly. Oral antithyroid medication, propylthiouracil, was started at 200 milligrams 4th hourly, and esmolol infusion was initiated and titrated for tachycardia. Target heart rate was less than 100. After stabilization, she underwent a CT scan of the chest, abdomen, and MRI, which showed metastatic lesions in the lung and the brain, confirming stage 4 choriocarcinoma. Oncology was consulted, and she was started on chemotherapy with etoposide, methotrexate, leucovorin, dectinomycin, and cyclophosphamide. The esmolol infusion was transitioned to oral propranolol, 60 milligrams 6th hourly, and propylthiouracil was transitioned to methimazole, 10 milligrams TID. Free T4 and T3 levels were monitored closely. The methimazole dose was further reduced to 20 milligrams daily, and propranolol was transitioned to oral atenolol, 50 milligrams once daily, to ensure compliance. At 2 weeks follow-up, patient remained asymptomatic. Methimazole dose was further reduced to 10 milligrams as the T4 levels were low and T3 levels were normal. For management of choriocarcinoma, she received 10 cycles of chemotherapy over next 5 months. HCG level downtrended and plateaued at 9.3. The normal non-pregnant level is less than 5. A low-grade chemotherapy resistance was suspected, and for the residual choriocarcinoma, per multidisciplinary team, she underwent total hysterectomy on day 113. The excised hysterectomy specimen showed a 6.6 centimeter tumor in the uterine corpus with hyalinization of the tumor surface. It was staged as PT1 and FIGO stage 1 as the disease was confined to the uterus. The histopathology showed these atypical cells scattered in the myometrium. On further resolution, we saw the clusters and scattered atypical cells, which are intermediate trophoblastic cells, classical for choriocarcinoma. On further resolution, these are pleomorphic cells, which are varying sizes and shape, with the pale cytoplasm and round nuclei. These are intermediate trophoblast cells, very classical of choriocarcinoma. At 1 month follow-up, she received 3 more cycles of chemotherapy after hysterectomy, and the HCG reduced to 1.7. The CT scan and the MRI confirmed resolution of the metastatic lesions. At 3 months follow-up, patient remained asymptomatic. The pain rating was 0 by 10. ECOG performance status was 0. Methimazole was discontinued, and she was continued on oral atenolol, which was ultimately discontinued at 6 months. This graph shows at the time of presentation for thyroid storm, the HCG, which is in the blue line, was elevated. The free T3 was elevated, the free T4 was elevated, and the TSH was suppressed. She was started on propylthiouracil. In the ICU, she received the first cycle of chemotherapy. The red lines show the chemotherapy cycles. She was transitioned to methimazole, and we see after 2 weeks, her HCG levels dropped. The thyroid functions started improving. She received 10 cycles of chemotherapy. At day 113, when the low-grade resistance was suspected, she underwent hysterectomy. Following that, she received 3 more cycles of chemotherapy, and at 200 days, her HCG and thyroid function test normalized, and she was off all the antithyroid medications and the beta blockers. Important clinical pearls that transient thyrotoxicosis can be seen in normal pregnancy. In gestational trophoblastic disease, the thyroid profile can be abnormal because of higher HCG levels. However, only 5% patients develop clinically overt hyperthyroidism. Colfers reported for every 10,000 increase in HCG, TSH can decrease by 0.1 and free T4 can increase by 0.1. This is because there's a cross-reactivity of HCG at the TSH receptor because of the common alpha subunit. Another thing is the HCG of pregnancy is different from the HCG of choriocarcinoma in the structure. HCG of pregnancy has a 31 amino acid extension called the beta CTP, and it reduces the affinity for TSH receptor and hence prevents hyperthyroidism during normal pregnancy. The HCG of choriocarcinoma is the NICT form, which is a more potent stimulant of TSH receptors. In patients with GTD, with thyrotoxicosis, if the HCG levels is not concordantly elevated, reassess by serial dilution because they can be falsely low due to Hick effect. And the medication the antithyroid medication should be initiated before chemotherapy as there is a risk of HCG surge and potential worsening of thyrotoxicosis. These are some important learning points from this case. The most important thing is the multidisciplinary team approach, and antithyroid are the mainstay of the treatment, and thyroid function tests should be closely monitored as patient can experience rapid improvement in the symptoms. Thank you.
Thank you, Dr. Garg. These cases are always ultra challenging and scare all of us. Anybody in the audience has any questions related to the case? Did you have any follow-up for the baby?
So this patient underwent the evacuation.
Yes.
And
My mistake.
yeah, this was a choriocarcinoma with metastasis, and the main thing was the treatment of the malignancy and stabilizing the thyroid storm and then management of the choriocarcinoma with the chemotherapy, multidisciplinary team with oncology, OBGYN, endocrinology, and intensivist.
Yes.
So that was the key to the success in management in our patient.
Yes, always prioritize the mother. Sorry, it slipped off my mind.
Yeah.
We have one question from the audience.
Yeah, this isn't really specific to the choriocarcinoma issue, but with thyroid storm, just wondering, I didn't see any use of iodine for the Wolff-Chaikoff effect after initiating methimazole.
Yeah.
Did you discuss that? Was that something you decided not to do? And you know, what do people think the value of that is these days?
Yeah, Dr. Suzanne is going to talk about this.
This then could be a great time to invite our third expert, Dr. Susan Mendel from UPenn.
Thank you.
So I too, like Bev, would like to thank Bill and Adina for inviting me to do this. And most importantly, Nidhi is a medical resident, so is interested in endocrine. So we really appreciate that, and we're really excited when more people go into endocrine. And this, like the cases from Memorial, these are incredibly challenging cases, and I congratulate your team for your care of this patient. So I have 5 points that I wanted to briefly discuss. And the first was just to re-emphasize the HCG of pregnancy, normal pregnancy. As we all know, HCG can stimulate the TSH receptor. Even in normal pregnancy, it is less potent than TSH, which is why TSH goes down at the end of the first trimester. But most importantly, The biochemical composition of HCG in a molar pregnancy is different. It's more basic, it's less glycosylated, and it looks more like TSH. TSH in its beta chain has one glycosylated chain. Normal HCG has 6, and in molar pregnancies, it's usually around 2, so it's much more potent, so that's very important. The second thing you could ask is then why wasn't this patient thyroid toxic at 6 weeks pregnancy when she presented, right? She presented 6 weeks pregnancy with vaginal bleeding and an HCG of 630,000. And the answer is studies have shown clinical observations that you need that elevated abnormal HCG for at least 4 to 6 weeks to become clinically thyrotoxic. But a very important clinical pearl, she presented with an HCG of 630,000. What is in the wonderful case report but not shown here was 2 days later, the HCG had only dropped to 530,000. The half-life of HCG is 24 days. So provided, again, you would recheck it because there are variations in the assay, there's even hook effects. But if your HCG did not decrease that much at 48 hours, that is a time to think that there's retained tissue producing HCG, and you might have intervened with scanning earlier. So a very critical point that our OB colleagues know is to watch the timing of the HCG drop. She then presented when one would thyrotoxic with a high molar pregnancy HCG about 5 to 6 weeks later. Whether we call this thyroid storm, whether we call this severe thyrotoxic, whether you use the Birch-Wertowski score or the Akamusa score from the Japanese Thyroid Association, this patient was sick, and you're going to intervene with the most important things we have. So PTU decreased T4 to T3 conversion, and if you looked at that lovely graph, you can see the T3 went down before the T4 did, because we did that. Dexamethasone will also do it. And that is the point that I would bring up. And I would like to tell you that yesterday, I don't know if Francois Verster is here, there was a lovely poster in the poster session from New Zealand about a man with metastatic choriocarcinoma and elevated HCG who was treated with Lugol solution alone. Our mainstay in the treatment of thyrotoxicosis, where the entire follicular cell volume is stimulated to produce thyroid hormone, here by HCG, not by a TSH receptor antibody, is iodine because of the Wolff-Chaikoff effect, which inhibits the uptake, the synthesis, and the secretion of thyroid hormone. And when you do that, the half-life of T4 in a thyrotoxic person is 3 days. T3, the half-life is 1 day, so much shorter than in a euthyroid patient, and they really plummet down. So SSKI could have helped here. This patient obviously did very well with PTU, with dexamethasone. Esmolol was used not for the T4 to T3 effect, because only propranolol does that, but because of the tachycardia, and then the patient was transitioned. So really nice management. The last thing I just wanted to say was people always ask about the timing of the drug, and we had this discussion beforehand, because initially 10 milligrams TID was used, and we know that, and that was a methimazole, excuse me, so the patient was appropriately transitioned to methimazole, which is longer acting, and we all know that adherence is incredibly important in these patients because in our Graves patients, our toxic nodular patients, they can become thyrotoxic. So how do you know the correct timing of giving a dose? And we're very fortunate, and I see a couple of people I recognize here that have some white hair, so they may remember these tests. But the way the timing of antithyroid drugs was determined over 3 or 4 decades ago was by using the perchlorate discharge test, which tells you how long that drug is effective in decreasing iodine organification to make thyroid hormone. And it turns out for 70% of patients, methimazole can be dosed daily. For 20%, it's a BID drug, and only for 10% is a TID. So for those of you in practice, definitely BID to once a day for methimazole should be sufficient. But again, an amazing case. I'm so glad she had this outcome. I'm sorry that it was a choriocarcinoma, which can only be defined pathologically, but really great care, and thank you for letting me discuss.
Thank you so much. Tricky pearls. Thank you again. So with this, we'll move to our last case. It's 2 cases, in fact, of improved bone mineral density following treatment of hypophosphatemic osteomalacia due to FGF23 excess. Will be presented by Dr. Lara McKinn, a combined adult and pediatric endocrine fellow at University of Washington.
Thank you so much. Good morning, everyone. Thank you for being here. I appreciate the opportunity to be here and present these cases this morning. So our first patient is a 43-year-old man who presented with 5 years of progressive hip pain, weakness, fatigue, and difficulty ambulating. 3 years prior to diagnosis, he had a DEXA that showed low bone mineral density and required surgery for a right hip fracture and prophylactic surgery of the left hip. 4 years following symptom onset, he was first noted to have hypophosphatemia, and genetic testing was negative for heritable causes of hypophosphatemia. He first presented to our clinic 5 years after symptom onset with continued functional decline and poor quality of life. Further workup at this time was notable for hypophosphatemia, evidence of renal phosphorus wasting, and elevated alkaline phosphatase. His 25-OH vitamin D, PTH, calcium, and creatinine were within normal limits. He had a repeat DEXA that showed a 34% decrease in bone mineral density despite 3 years of treatment. Given years of progressive symptoms, evidence of hypophosphatemia and renal phosphorus wasting, and negative genetic testing for hypophosphatemia, there was a high suspicion for tumor-induced osteomalacia, which is a rare cause of FGF23-mediated hypophosphatemia. His FGF23 was found to be elevated, and imaging subsequently revealed a 3.5 centimeter superficial subcutaneous left flank mass corresponding with a palpable mass on exam. He was initially on phosphate supplementation, and calcitriol was prescribed while awaiting surgical removal of the tumor. Pathology revealed an infarcted angiolipoma with extensive calcification, consistent with a phosphaturic mesenchymal tumor, which is the most common tumor type implicated in tumor-induced osteomalacia. His phosphorus and calcitriol were able to be discontinued. Following surgical removal, the patient had notable improvements in symptoms and functioning and recovered his ability to ambulate. His serum phosphorus and FGF23 levels normalized. He had a DEXA 8 months following surgery, and it remarkably showed doubled lumbar spine bone mineral density. He continues to do well with occasional clinical and laboratory monitoring. Our second patient is a 48-year-old nonverbal man with autism and intellectual disability who presented with months of declining mobility and apparent pain. 7 months prior, he had a DEXA that showed severely low bone mineral density, and a bone scan at that time revealed several fractures in different stages of healing, prompting an investigation that showed no evidence of abuse. He was ultimately admitted to the hospital given inability to ambulate unassisted, and imaging revealed a non-operative fracture of the left hip. And endocrinology was consulted at this time given his low bone mineral density and his fracture history, and this is when he was first noted to have hypophosphatemia. Further workup was notable for renal phosphorus wasting and elevated alkaline phosphatase. He had a mildly low 25-OH vitamin D, but his PTH, calcium, and creatinine were within normal limits. Following discharge, he continued to have hypophosphatemia refractory to oral replacement, and while undergoing further workup for his hypophosphatemia, he was found to have a right femur fracture requiring surgery, in addition to a healing stress fracture of the left hip requiring prophylactic fixation. With prior documentation of normal phosphorus and his age of presentation, an acquired etiology of hypophosphatemia was suspected. He was found to have low 125 dihydroxyvitamin D and elevated FGF23, consistent with FGF23-mediated hypophosphatemia. He was continued on phosphorus supplementation and prescribed calcitriol, and over the course of 7 years, no causative tumor has been found despite extensive imaging, including whole body MRI and dotatate PET CT scan. With appropriate medical therapy, he had notable improvement in mobility, and a DEXA was repeated 3 years following initiation of medical therapy and remarkably demonstrated 48% improvement in lumbar spine bone mineral density. With medical therapy, he has had no further fractures, and his phosphorus levels remain low to normal, and he continues to do well clinically. Our major takeaways from reporting these cases include that TIO is a rare cause of osteomalacia due to FGF23-mediated hypophosphatemia. It's important to check phosphorus and alkaline phosphatase levels in patients with bone pain, muscle weakness, and fractures. Patients with FGF23-mediated hypophosphatemia usually have elevated alkaline phosphatase, evidence of renal phosphorus wasting, low 125 dihydroxyvitamin D, and elevated FGF23. And most importantly, recognizing and treating FGF23-mediated hypophosphatemia can result in substantial improvements in patient functioning, quality of life, and bone mineral density. Thank you.
We have time for 1 or 2 questions from the audience.
Thank you so much for the case. Mamoun Salam from Washington University, St. Louis. A couple of questions. With the first case, how long did it take for you to taper the phosphorus supplements for the patient after the surgery? Like how many days? And then with the second case, the imaging, did that include like all of the body, including head and hands and feet? Thank you.
Thank you for the questions. For the first case, I believe it was within weeks that he was able to discontinue the medications. And then your second question about the imaging, he did have whole body MRI and whole body dotatate PET CT scanning.
Good morning, Azar Khosravi from Cedars-Sinai. I was wondering if genetic testing was done for the second case, because I'm not sure it's actually a TIO, because you haven't, really ruled out genetic causes of hypophosphatemia. And I was wondering, especially for the second case that is unresolved, have you considered starting burosumab anti-FGF23? Anybody?
These are both really great questions, and we talked about this. The second patient is in a group home and has intellectual disability. He has no offspring. So when the question of genetic testing came up, the idea was that management essentially wouldn't change, that the phosphorus and calcitriol would be sufficient to manage his case. And the idea of burosumab, it was not FDA approved at the time of his diagnosis. And this was another discussion with the patient and his guardian. And he's doing really well with medical management and has not had fractures and has been ambulating fine. So he has not been started on burosumab.
Sorry, management would be different, because if you're assuming it's a TIO, you're obligated to revisit imaging with dotatate every few years. But if it is genetic, then you will have to have on medical therapy for life. That's, it does make a difference.
I realize that it's more osteomalacia, but I was just curious what their T-scores were and how severe that reduction.
It is in the paper. The first patient, I believe his T-score was -3. I'd have to go back and verify. I think I have it in the notes in this presentation somewhere.
Okay, no problem. We can talk later. Thank you.
One more question.
Gordon Cutler, Deltaville, Virginia. I realize that the second patient had a lot of difficulties. I wondered if you had given any thought to vascular sampling and looking for gradients. I once had a patient with precocious puberty a boy, very high levels of T, actually above the upper limit for adults. All the imaging was negative, but both arterial and venous sampling, arterial with small amounts of dye and then venous sampling, revealed a gradient, a very slight gradient in alpha subunit in a tiny area, a tiny vein from the thymus, and he was cured surgically. So I wondered if you thought about looking for it that way.
That's a great question. I found some evidence of using that for testing when imaging doesn't find a tumor, and spoke with my mentor about this. And I don't know the ins and outs of how that testing is done, but I imagine it may be invasive. And with this patient who was doing well on medical management, it was decided not to pursue that testing.
Well, in this case, it was done by John Dotman at NIH, who was an absolute phenomenal. He's the guy who helped us learn you could do petrosal sinus sampling and always get into both things. And he could do it so fast, he could leave a conference and say, "Excuse me, I got to put in a couple of catheters," and he would come back in 10 or 15 minutes, and both petrosal sinuses would be catheterized.
That's very nice. Thank you so much. We'll invite Dr. Tom Weber, who's a bone expert from Duke University, to share his experience with these cases.
Well, thanks to Bill and Adina for inviting me to be part of the session. It's wonderful to be here, and it's a great case by Laura. Cases. And I'm biased, but I think TIO and its subsequent cure is one of the most exciting and satisfactory parts of endocrinology. I mean, over 30 years, I've had several cases, and to have folks be wheeled in wheelchairs with multiple fractures and regain full functional status, we don't really get that in medicine in general, and I think it's exciting in that regard. So the cases were beautiful. But I wanted to focus on a few teaching points, and I'll put them into 3 buckets. And the first one is the diagnosis, and it starts with the phosphorus. And this is where it's a challenge, and this is why there's a delay in diagnosis, because phosphoruses are not part of routine chemistry panels. And I've actually spoken to heads of LabCorp, et cetera, about retooling their platform to include phosphorus, and financially it doesn't make sense to them, so they won't make that change. So unless you have a suspicion for it, and Laura's point about measuring a phosphorus level and alkaline phosphatase in every patient who presents with low density and fractures is critical. But I think the delay, with the internists and people who are taking care of these patients really wasn't thinking about that, and that's what leads to the delay. Once you've established hypophosphatemia, it's important to establish renal phosphate wasting. And how that's done is typically a 2-hour urine collection fasting in the morning. The first void is discarded, and the second, there's a 2-hour collection, and the patient comes in from home and has a blood test for phosphorus and creatinine, as well as concomitant urine phosphorus and creatinine. And you can calculate what's called a FEPA, a fractional excretion of phosphorus. And that will document that they have urinary phosphate wasting. And that's critical to identifying, because there are other causes of hypophosphatemia, obviously, nutritional, et cetera, that present. And then, so once the renal phosphate wasting is established, back to the question, I think the third questioner about genetic testing with panels, hypophosphatemia panels. The onset in later in life obviously would argue against it being genetically based, so I think it would argue against genetic testing in case number 2. It was done in case number 1, and nothing was found in that regard. But those are easily obtainable through multiple platforms, and I think it's important in patients, particularly if the onset of disease in terms of hypophosphatemia with fractures, growth disturbances, dental abnormalities, to do that testing. It was reasonable to do it in case 1 as well. So that's important to establish. And I'll talk in a bit about treatment, why it's important from a genetic standpoint to identify certain disorders in terms of affecting the treatment in a few minutes. So diagnosis is often delayed, and you have to think about phosphorus and measure it in order to at least start going down that pathway in that regard. As far as localization goes, it's not uncommon to not find a tumor. Recent review from 2022 showed that about 15 to 20% of patients with TIO are non-localizable. And there's a very high prevalence or incidence, of recurrent or persistent disease that occurs as well. So that's where medical therapy is really critical in that regard. We actually found at this meeting yesterday from Hoshina and colleagues from Tokyo that we now have a new entity. It's called AIO, which stands for Autoimmune Osteomalacia. And they described 5 of 13 patients with non-localizable TIO, tumor-induced osteomalacia, who had positive antibodies, autoantibodies to PEX, which is the critical factor and the gene that's disturbed in X-linked hypophosphatemic rickets. So it's exciting. Now we actually have potentially a way to actually identify some patients who may have autoimmune osteomalacia, and that will make a difference in terms of diagnosis and management. And then on to sort of the treatment pearls here. And the first thing that we're taught in medicine is do no harm. And patient number 1 received teriparatide, but also received years of bisphosphonate therapy. Bisphosphonates, I don't know how many of you know the story, but it was a serendipitous discovery. Bisphosphonates were initially developed to inhibit mineralization. And they were going to line washing machines and municipal water supplies, but they had to do the animal experiments to make sure that if there was human exposure, it wouldn't cause issues in that regard. And when they did it, they expected that they would take these rats and they'd be able to break their bones very easily, and they couldn't break their bones. So it was completely serendipitous. So it was a dose-dependent effect of bisphosphonates. And so in the presence of osteomalacia, you can often aggravate or worsen osteomalacia. And then patient number 2, I believe, also had fractures. Patient number 1 had fractures on bisphosphonate therapy. So it's really important not to do harm. With regards to treatment, back to the genetic causes, phosphorus was used in patient 2, and that patient actually progressed in terms of the disease with recurrent fractures. There is a genetic condition called HHRH, which is hereditary hypophosphatemia with hypercalciuria, which is due to mutations in the sodium phosphate 2C transporter. And what happens is you actually just have hypophosphatemia without the other disturbances that you see in many of the hypophosphatemic disorders. So you can give phosphorus alone. But if you give phosphorus alone to all the other conditions, including TIO, you will aggravate the hyperphosphatemia because you stimulate PTH, and you will lower FGF23, which will stimulate FGF23, which has been shown to aggravate the phosphate wasting. So you really want to treat with calcitriol. And when this gentleman in case number two, was treated with calcitriol, then he turned around with regards to his clinical response. So that's important to note. And then just a point about the bone density response. Again, one of the most dramatic things you'll see is 100% improvement in bone density. And remember, DEXA cannot distinguish unmineralized osteoid from low bone density. And so what this patient had is a huge amount of osteoid that was rapidly mineralized and quickly reaccrued bone density. So it's important to take that important. And again, it's very, very satisfying. But wonderful cases, Laura. It really was dramatic improvements and really enjoyed it. So.
Tom, thank you very much for those pearls. So this concludes our pearl session. Please join me in thanking our presenters and our content experts.